Thanks very much, Sandra, and thank you, everyone. Good afternoon. Thanks for inviting me to present a new online digital resource to empower and support primary care professionals to set up cancer care review clinics and provide impactful and meaningful reviews using the learnings and best practice tips from professionals working in primary care. The guide is aimed at all healthcare professions, and we're going to have a little bit of a discussion about that afterwards, delivering cancer care reviews in primary care. So whether that's cancer care coordinators, GPs and or other roles such as social prescribers, as well as practice nurses. Now, some of you I know me because I have been around in cancer for a long time, but I've worked in cancer for over 22 years. Most recently as a cancer nurse specialist, as a head and neck cancer specialist nurse. And prior to that, or in between those jobs and that, I actually worked for Macmillan during the development of the recovery package. So I was, that's over 10 years ago now. I can't believe that the recovery package has been going that long. And I thought when I became a practice nurse that I would, I'd know how to do cancer care reviews because I'd lived and breathed them for as long as I did. And how naive could I have ever been? Over the past 2 years, I've had to learn through a very trial and error approach. And as a result, have had a lot of learning to share with other primary care professionals, both what's worked and what's not worked. And many others who are setting up cancer care review clinics for the first time have approached me for advice or to shadow me in practice to better understand what's involved and perhaps what a good review might look like. So it was clear that there was a real demand for something over and above what we already had developed in Macmillan that was much more around this is a good way to set it up. So not what is a cancer care review, what's the purpose, what are the benefits? It was more around actually the practical setting up. What are the codes that you need to use, the SNOMED codes, etc. And so hence why I started to develop it. And alongside that, it was very obvious from some of the personalised care facilitators or cancer network facilitators that were trying to develop something very similar. And rather than having, 57 Heinz varieties, we decided that perhaps if Macmillan could do this, then it would be a digital resource that could be updated very quickly. And there would still be a need, obviously, to develop then locally. Perhaps what do you need on top of that was never to replace local, but was very much, at least this would be a start of a 10 and a degree of standardisation then across the UK. I developed it with lots of stakeholders across that are involved. So Sandra had seen it and was one of our experts on sort of looking at it, and lots of other people. I won't name them all, but they are in the back of the resource if you want to have a look. Next slide, please. I don't know whether I can do it or not. So I'm just going to put in the chat the hyperlink so that you can actually click on the hyperlink yourself. But when you click on the hyperlink, there's a digital version of this. So this isn't exactly what you'll see, but you can download it. So this is the front page of the downloadable version. It does have version control, you'll be pleased to know. So that's the downside when people download things, is obviously it may not be the latest version, but it will always be the up-to-date version that's actually on the Macmillan website. So as I say, you can either use it digitally or you can use it as a PDF download. It's split into 6 easy to read sections. I'm not going to actually show it because you can look for yourselves, you're all intelligent people, but there's the first section is about preparation. The second section is about setting up QOF indicator CAN 005, then setting up QOF indicator 004, then sort of top tips for meaningful cancer care reviews. Then there's a section on evaluation of cancer care reviews, which I know is the second section, so that would be great. And then the sixth section is further information and resources. And over time, as I say, we'll be able to add. So if there are other good examples of what's going on around the country, we can always add links into those so that it actually becomes almost like a live, meaningful resource for everybody. And obviously, we now know that QOF hasn't changed, but there was some discussion that whether Cancer Cough might come out this time round, but I'm sure you've all seen in the last week that Cough and CAN 001, 004 and 005 remain. So we're always happy to have thoughts, feedbacks, what's working, what's not working. As I say, it'll only ever be as good as what people tell us and what people feel that they need. So please do feel free to feedback through either your local Macmillan representative, whoever you liaise with locally, or me directly on either the NHS or the Macmillan web email address. So that's it. Yep, good news, Sandra, about Cough. Yeah, that was my biggest fear, was that if that came out, that might make it challenging, even more challenging than it already is. And then the next slide, please, Sandra. Sandra and I have had lots of conversations, and we have different, some divergence of views and that around the workforce issues, and we thought it would be a really useful discussion to have, a healthy discussion to have, to say, what are the workforce issues delivering cancer care reviews, and I think some of the controversy is around whether it should be done by a registered professional, and or whether or not it can be done by, particularly obviously, the Rs funded roles. And there's a real variation across the UK, or certainly, sorry, across England, that I've seen and heard from social prescribers, as I say, and others. So it was really just to open that discussion up, really, and see whether people are prepared to share their views perhaps on that.
Thank you, Jacqui. Does anybody like to kind of start that conversation off? Catherine.
Hi everyone. Hi Jacqui. Thanks very much for that presentation. We did meet briefly last year, I think it was, at one, down in Birmingham, was it, I think? But yeah, no, that was really helpful. And I know actually the cancer care review page is something that I certainly use a lot of when I'm sharing that with the people that are delivering those in primary care. So my role within Lincolnshire ICB is that link into primary care, and certainly myself and I've got another colleague on the call here, another two colleagues, we support primary care in their delivery of the cancer care reviews. Certainly that's something that we've picked up across Lincolnshire. We've got about 15 PCNs, and we've got one in particular that's got a number of practices where across all of them now, they've got cancer care coordinators who are doing lots of different roles. But interestingly, I spoke to a member of their clinical staff yesterday who's very much still feels that that should be a clinical role. She's happy for them to do a certain amount of it, but almost still isn't quite prepared to hand it over in its entirety just yet. So I think that's just a general observation across our county, that you're right, there's still some people that are very much, they've got their in-house social prescribing link workers, they're happy for them to do it, refer into a clinician if that becomes necessary, and then there's still other practices that very much want to hold on to it. So for us, it doesn't feel like there's a one size fits all. We all, we talk about personalised care, and it's almost that each practice has to do it in a personalised way also that suits them. But yeah, that's the observations that I have anyway in Lincolnshire, so I just thought I'd share those.
Thank you.
Catherine. Anyone else? Bana.
Hi, I work in Kent, and I'm a GP by background. Just coming to the previous notes, I think it's very important to distinguish between which cancer care review, because we got the first 3 months and the year, and many of the PCNs or the primary care team are quite happy to hand over the 3 months one to cancer care reviews, which we have in many PCNs, or the practice nurses or any other healthcare professional that they know what they're talking about with the patient. But when it comes to the year, the second one, which is more like medical and going through the side effect and the possible sign of recurrence, I think some medical background would be quite useful, and that make it a big difference which cancer care review we're talking about.
I think a lot of it.
Good point, Bana. Sorry, go on, Jacqui.
Yeah, no, I was going to say the same. Yeah, it is a really good point. And I think sometimes it's not helped by the terminology we use. So I always refer now to the first 3-month one as a support conversation. So I think the initial support conversation, you know, is actually a listening exercise predominantly, you know, and obviously providing emotional and practical support as well. But there's a degree that probably, you know, anyone that's well trained could do that. I think though any role, regardless of whether it's a 3-month or 12-month role, does need to work within a skill mixed team where they can escalate things beyond anybody's competence and knowledge and confidence. So even myself, there's still things that I would refer to the clinical pharmacist, you know, or the GP directly if there was a specific question. So I think it is about making sure that, you know, you're working within a team where you can escalate, where, you know, there are clear boundaries and in place, so that, you know, no one is trying to work outside of their, you know, of their professional boundaries or their knowledge boundaries more than anything.
Thanks, Jacqui. I think that's a, you know, it's obviously a really, really good point. And Bon, I think you've raised an interesting kind of point there around distinguishing between the two reviews. I think I would probably favouring with your view that I would see the 12-month review as having an element of clinical care about it. I think if we want to make sure we're not missing important things, if we want to help prepare patients for their future care, I think that sort of clinical aspect to it is important. And I know that not everyone shares that view, so definitely want to hear others' thoughts on that. But I suppose the challenge is if somebody is seeing a non-clinician, if there is a clinical concern, kind of what happens to that? Does it get missed or does it get picked up? Is there a way that we can triage these kind of care reviews so that when there's likely to be clinical issues, that they're definitely being seen by a clinical colleague as opposed to non-clinical? Is how I would describe probably roles such as social prescribers or cancer care coordinators. But anyway, good to hear other people's views as well. So I can see a couple of hands up. But it's difficult for me to see people's full names. Sorry, Joyce.
Yes.
You there, Joyce? And we're not hearing you at the moment. Okay, perhaps we'll come back to you. I'm not sure there's a problem with your mic. Ellie, I can see you've got your hand up.
Thank you. Yes, I also work in Lincolnshire, and it's something that we go back and forth on because, you know, I absolutely take the point that a lot of patients will have those clinical needs, and it is really important that those are met and the patients are safety netted clinically. But then there's the other stuff around the cancer care review, that more holistic care and the local knowledge about what people can access for support, which sometimes those non-clinical roles know more about in terms of the local area, in terms of what's available, in terms of how to signpost people. So I would say that, you know, what we really strive for is that if a clinician is doing it, for them to have their information at their fingertips, or to be able to refer the person back to their social prescriber or their coordinator. And if a non-clinical person is doing the cancer care review, to make sure that they've got that really, you know, that they absolutely know what to look out for and have very clear lines about when to escalate it to somebody clinical. And it is really, I mean, I'm really interested to hear other people's views, because, you know, even within the county we have practices doing it very, very differently, and both feeling quite strongly about it.
Thank you, Ellie. I'm going to try and get back to Joyce. Joyce, are you able to talk?
Yes, hi, I hope you can hear me now.
Yeah,
Yeah.
you now.
Just wanted to share, for me in Berkshire West, I have a care coordinator who's doing cancer care review, and I think it's just highlighting the boundaries. And with this care coordinator, she was doing cancer care review, and while doing that, she discovered that the patient itself is a carer for a husband who have the dementia. And it was just right timing and everything, catching all these things and referring it back to the GP. So they have managed to work as a multidisciplinary team, dealing not just the patient but also the relative. And I think this is a good thing as well, like understanding the boundaries and the red flags that they need to escalate to the clinical people. And I think that's a very good thing for care coordinators to know. That's it. That's all. Thank you.
Thank you, Joyce. Tanya, did you want to come in?
Hiya, yeah, I'm from Cheshire and Merseyside, and kind of wanted to echo what other people are saying, that we've got very different views across our patch about who should be doing cancer care reviews. But I also I wanted to mention a piece of work that Greater Manchester Cancer Alliance have done. I don't know if there's anybody on here from Greater Manchester.
Yes, I am, and I've got my hand up.
Oh, right. Shall I let you go then?
No, go say what you were going to say.
Well, basically, the Alliance have had a project where they've funded cancer care coordinators in all of the PCNs. And one of the really interesting things that came out of that for me is, obviously, if there's capacity in primary care for a clinician to do a cancer care review, then that's great. And if that's what they choose to do. But we know that obviously capacity is a massive issue in primary care. And one of the things that I noted of interest that came out of the Greater Manchester piece of work was big reductions of requests for on-the-day appointments from patients with cancer, because they have gone to their cancer care coordinator and got the answer that they needed from them, and therefore didn't need an appointment with a healthcare professional, which, you know, I just thought was amazing. I'd probably like to hand back over to whoever is on from Greater Manchester, because I don't want to steal your thunder.
Thanks, Tanya. Is that you, Miranda?
Yes, it is. Yeah.
Right.
It's not my project, I must say first. It isn't me. I've come along afterwards, but I'm a personalised care manager for the Alliance, so I've kind of taken on the project, the aftermath of the project. But absolutely, I think that the project has shown that the value of the cancer care coordinator role goes beyond the cancer care review. And I think that's the point that I was going to make, is that a lot of the cancer care reviews are cancer care coordinators, are able to follow up patients and develop a good relationship with patients, which I don't think the GPs have time to do. As part of our, of course they have time to develop a good relationship, it's just a different kind. Part of our work with the cancer care coordinators was to sort of establish a standard for cancer care reviews, and we sort of recommend a good 20 minutes to undertake a proper holistic cancer care review, and that's not really time that GPs have. It would take up a lot of their surgery to do cancer care reviews in that way. And I think the importance of embedding cancer care coordinators, or whoever does the reviews, into the team, so that they know where to escalate difficulties to, they know what to do if a patient hasn't had a med review and needs one. If there's a pain issue, they know what to do with that. But I think the local knowledge that the cancer care coordinators have, because they have been able to go out into the community and meet with groups and organisations that support patients, enables them to sort of support that transition from treatment through to living with cancer or living beyond cancer. And to me, the cancer care review is an extension of the holistic needs assessment. It's the primary care version of the HNA. So it's about the patient and their life and their sort of well-being, as well as the cancer, the sort of the clinical stuff. But I think primarily it's about supporting them to live once they're no longer under the wing of their clinical team.
Thanks, Miranda. That's helpful. Jacqui, I can see you've got a follow-up question, which I actually think fits in quite nicely at this point in the discussion around evaluation. So I'm thinking, we're talking about different models of care. How do we kind of provide the evidence as to, which is better for patients? And from my kind of knowledge of the literature, in terms of what's being published, it's really limited. Anything that's been published really is pre the QoF change. So I think we've got limited kind of intelligence in terms of research. But what we do have is lots of projects and, the opportunity to actually generate some of that knowledge that we need to kind of really unpick this and understand what the benefits are of the different approaches. So keen to kind of hear people's kind of views on that, particularly where there's been implementation or a change in practice. So for the Manchester colleagues, for example, I've seen your evaluation, which looks great, but I would say it's looking very much at process and not necessarily looking quite so much at maybe patient outcomes or patient experience, but really happy to be challenged on that if I've got it wrong. So keen on people's thoughts. So is it Katie, you've got your hand up? Was it Kathy? Sorry.
Yeah, hi there. Can you hear? Yeah, hello there. Yes, once again, I'm from Lincolnshire. Sorry, we're here en masse today. So here with my two colleagues. So in Lincolnshire, we've always had or struggled to demonstrate the impact of the whole Living with Cancer programme. So last year we developed a dashboard which measures the quantitative data, but it also measures the qualitative data, the so what, if you will. So it's all very well, for instance, to do a cancer care review or a holistic needs assessment, but what actual difference did it make to people? Now, to be fair, we haven't done one of these on a cancer care review yet, but in the future, I really hope that we will. But we've developed a methodology whereby we can quantify qualitative data in the form of case studies. So we have a panel who looks at case studies and from that applies a health value. And we're also working with system partners to see if we can apply other values. So for instance, social value. So looking at can we bring the social value engine into putting I suppose a pecuniary value on our case studies, because face it, when it comes to securing funding, it will be directors of finance and they will want to know whether they're going to be, what bang they're going to be getting for their buck. Is there going to be a return on investment to put in place roles, etc. We are very early on in our journey, but if anybody wanted to meet with us and we can describe in more detail what we're doing with our qualitative data, we'd be very happy to share.
Thank you, Kathy. That sounds really interesting. It sounds like a really good topic for a future discussion group.
Oh no!
At some point,
I've done it now.
When someone's ready, perhaps when someone's ready to present, it would be a really good thing to share. Yeah. Personally, be interested in making contact with you and having a chat. But I'll touch base.
We'd be very happy to share our whole dashboard. You know, all the quantitative stuff as well. It's an amazing piece of work. So yes, do get in touch. Thank you.
Lovely, thank you. Is that Tanya? Have you got your hand up?
Yeah, hi Sandra. So I'm Tanya, a GP in Tower Hamlets. Hello. I had a couple of points really. So Kath, that's really super interesting because we were part of the MLAP program in Tower Hamlets, and the $1 million question was how do you show savings from various interventions. My other point really was, I suppose, it goes in line with the pack you've just presented on personalised care, is what we struggle with in primary care is evaluation of the intervention when each intervention at every practice is completely different. So I know that what I'd love to develop or work with other people, maybe understand if someone else crack this, is a lot of the primary care PCNs and practices
where we're asking them to improve the quality of the CCR that they're doing for QOF, and trying to encourage them to do quality improvement work without any further funding to enable change. What they're saying is, but do you have a tool I can use to check with the patient as to what I'm doing at my practice is helping them? So I know that there's been various florries developed, but I'd love to hear if anyone has cracked a widget that we can give primary care to say, right, you guys think you're doing a really good job, right? Okay, so great, you're doing that, and you're not doing the same as that practice because you don't have the practice nurses. But actually, if you're going to send out a paper questionnaire or a 3-item questionnaire at Accurix, these would be the pertinent questions which we know we've evaluated are very helpful. Because what we're really missing in primary care is enabling people to reflect on whether what they think they're doing is having an impact, without it being a huge 20-question thing. And we obviously, like many patients, people on this call, deprived areas, English non-first language, there's different ways of getting feedback. But I'd be really, that's what we're trying to develop in North East London anyway, some sort of widget for primary care that we can help them sense check whether what they're doing is of use. I know the answers may be straight away, Sandra, but if there is if I can canvass opinions, or if someone can drop something in the chat or interested in contacting us, it would be great to work on something like that.
Thanks, Tanya. I would definitely be interested in talking to you about that, Tanya, cool. Offline. And if there's others, then drop me or Tanya a line and pop your emails in the chat. Jacqui, is there anything else you wanted to say to kind of wrap this up? I'm just conscious of the time.
Yeah, no, conscious of time as well, which is why I've sort of butted out, really, which is very unlike me not talking. So yeah, no, happy to hand over, because obviously the next bit was about evaluation anyway, so it kind of lent itself.
Lovely, thanks. So I'm going to pass this on to our next 2 speakers. I'll leave you to introduce yourselves. So over to you guys. Hassan, I think I've given you control of the slides, hopefully.
We can't hear you, Hassan. No, still nothing. No.
How about now?
Yeah,
perfect. Ah, fabulous, yeah. Brilliant. So hi everybody, my name's Hassan Tahir. I'm a GP up in Middlesbrough, and I am the personalised care lead for primary care at the Northern Cancer Alliance, and I'm a clinical advisor for Macmillan, so I work closely with Jacqui as well. And I've got one of my colleagues with me today, Sarah, if you'd like to introduce yourself as well.
Hi everyone, thanks for the invite today. I'm Sarah Kucukmehn. I'm the care coordinator leading cancer and inequalities in South Tyneside.
And just a really excellent discussion so far, really, and a lot of the same issues that we've had up in the Northeast as well, essentially around one size doesn't fit all for every practice or for every PCN, so we're having to tailor things and look at how, as an alliance, we can help support practices and PCNs implement a cancer care review system. And also the last part, I'm sorry, I forgot your name, from my colleague. The real sort of the golden ticket is, how do we get an evaluation to show the impact that these cancer care reviews have on patients? Having meetings with ICB directors, it's so difficult to translate the impact this has to nice fancy charts and pictures and money versus X and whatnot, which is what a lot of finance directors are used to seeing. So it's nice to sometimes hear that other people are having the same issues, but hopefully I'm sure at some point we can get our heads together and find a solution that will really help us get the resource and support that we need to help support our patients. So I'm going to whistle stop too. There's quite a lot of slides, but I'm going to skip over a lot of them because we're hoping people could reflect back on these in the time, and really wanted to use the time for more discussion towards the end. I'm going to see if it'll let me skip slide, but it's not letting me. I'm just going to. Oh, brilliant. So there's not a huge amount of evidence out there about the impact that cancer care reviews have. This was a review article that was done only in June 22. About what comparing what patients and what clinicians felt the cancer care reviews were delivering. Next slide, please. So whether I can skip slide. Second. Oh, there we go. Brilliant. So the evaluation that what showed really was a lot of lack of structure and guidance from corporate how to deliver the cancer care reviews, poor training, and generally not understanding enough as to what the cancer care review was there to do. A lot of people felt that the cancer care reviews were too early, and others felt that actually they were just too opportunistic, not happening at the right time or giving the right information to patients. When we look at how cancer care reviews generally reflect with NC pairs, tend to be relatively poorly. So initially, when people look at what the support they get from the GP practice, and they score relatively highly, and that is how often they spoke to the GP surgery before they got the referral, and when their diagnosis was fully explained to the patients. But when we break that down to whether they got the right support from the practice and whether they got an actual review of the cancer care review, we can see the scores drop quite massively. And this is something that's reflected across the country, not just something that we're seeing up the northeast, but I'm sure everybody in all the areas are seeing something similar from patients. So we looked at comparing two areas. One was two GP surgeries in Gateshead, who were running a traditional cancer care review model, where it's run by GP partners, and compared that to a cancer care coordinator project where run by Sarah and her team, who have got a set of cancer care coordinators who are running the cancer care reviews from there. And we looked at comparing the quality and how the cancer care reviews were conducted and the impact that had on GP surgeries and on patients. So I'm just going to use the opportunity to bring Sarah in just now, and Sarah's going to tell you all about this excellent service.
Hi, yeah, I apologise now because I do talk very quickly, but it's probably useful today. So this is the team which is led by myself, and we also have an additional cancer care coordinator starting in April. I came into post in February 2022, and part of my role was to create additional capacity for primary care to support those patients with cancer. We're all employed under the additional roles reimbursement scheme, but with the new cancer care coordinator, they've been funded by Macmillan. All of the cancer care coordinators are band 4. I'm a nurse of almost 30 years experience, varied background, mostly working outside of the NHS on cancer quality improvement in primary care, and most of that was in early diagnosis. Initially, there was only 2 cancer care coordinators and myself, but with the success of the service, we were able to recruit another member, and then that made us 3, and then more recently to 4. My task when I came into post was actually to create a sustainable quality cancer care coordination service for the patients of South Tyneside. And I've got a few slides now to show you how we've done that. But I think first of all, it's really important to share a little bit about the demographics of South Tyneside. Can we move the slide on, please? Oh, can I do that? Sandra, sorry, thank you. So this is South Tyneside. It's a coastal town in the northeast of England on the east coast. You may have heard of Sunderland, Gateshead, or even Newcastle. We're up there with the rest of the population in the northeast. The population of South Tyneside is about 150,000.